Good afternoon. Thanks for joining us here at Inspire Respiratory Critical Care's now bi-monthly panel discussion. We have a special guest today, Dr. Nick Ione. Say hi, Nick.
Hi, Nick.
That's like say hi. Never mind. Say hi to your knee. Thanks to everybody for that's a dad joke. Thanks everybody for
I got
joining
it.
us
I got the dad joke. I'm a dad, so
today. Appreciate everybody showing up. There's a chat box that you can ask questions during the discussion. Today we're going to talk about how to choose PEEP. Is it really that simple? I say no, it's probably not. And if you have a question or a statement or anything, go ahead and put it in the chat box. We ask you to go ahead and tell us where you're from, just so we have a general idea of the diverse areas and locations, geographical locations that folks are signing in from. So before we get started, we'll go ahead and everybody introduce themselves. Tom.
My name is Tom Pereno. I'm a respiratory therapist up here in Canada.
My name's Keith. I'm a respiratory therapist in Virginia. Nick?
my name's Nick. I'm a home crit doc currently in Virginia,
Northern Virginia, way up
Northern
there.
Virginia. Yeah.
That's right. Danielle?
I'm Danielle Hardy. I'm an adult critical care specialist respiratory therapist at ECU Health in Greenville, North Carolina.
Andy?
Good afternoon. Andy Klein. I'm a respiratory therapist and educator from Chicago, Illinois.
And John?
Johnny Crott, flight respiratory therapist from Advent Health, Orlando, Florida.
And thank you. Welcome all. We have a couple other people that probably join us as we're moving on here. Like I said earlier, we are going to talk about how to choose PEEP. We typically, if you've ever been to one of these panel discussions, we do them live and then we will record them. We're recording it and we will post it on link. And if you reach out to me, my email address is on the very last slide. If you don't have LinkedIn and you'd like to have access to the, and we also put them on our website. So we'll give you the web address for our website also. And there's somebody put a real fancy QR code on there that you can follow that and it'll take you to our website also. But if you've ever been to one of these, you know that we kind of do this very organically and we don't use a lot of detail. For most of us, it's very unusual to discuss topics without showing a lot of evidence and discussing a lot of papers.
Sometimes don't make a lot of sense.
And we don't always make a whole lot of sense, but people will keep us straight. So that's about what's going to happen here. So who wants to start out talking about positive end-expiratory? I always wanted to have an accent so I could say respiratory therapist or expiratory pressure, but I can't get away with it. Who wants to start us out, Tom?
I mean, sure. I think most people watching, I hope if they take care of patients on ventilators, you know at least what PEEP is. Positive end-expiratory pressure. It maintains a specific level of pressure in the lungs. This pressure could be higher, of course, if someone has intrinsic PEEP on top of the set PEEP, but rather than allowing the pressure to just fall down to atmospheric pressure, it keeps the airways and alveoli hopeful. This is up for debate. It has the potential to keep airways and alveoli open. It really depends on the underlying patient and the level of PEEP being used, of course.
Anything you see on these slides is going to be up for debate. And, that's what makes this whole adventure adventurous. But yeah, that's, so thank you, Tom.
No problem.
You're very controversial, Tom.
I am, yes. I always try to be.
So we're going to go through and we're just going to discuss the different, there may be, this is sort of, just sort of a list of different approaches that we've discussed previously in terms of how to choose PEEP, different methods of choosing PEEP. It's not all inclusive. I'm sure that we're forgetting something, and hopefully somebody will bring that point up as we go through here. So one of the simplest ways that we have discovered, where did the PEEP FiO2 table originate? Was it the ARMA trial? Was that the first time anybody ever talked about PEEP FiO2 tables?
I mean, it's the first time I was aware of one. Whenever anyone references it, they typically say the ARDSNet PEEP table. So I don't know. I honestly don't know if if they were the
Was
OGs.
it ARMA or was it the alveoli?
Alveoli was after ARMA, and they definitely used the PEEP. They used the low PEEP table, and so the alveoli was they basically added a different PEEP table, but I think it was the same low PEEP table that they used in ARMA.
Where did they get the table from? 100%, you go to 24 PEEP.
I think it likely was, and again, I'd have to look this up, but typically that stuff was like expert consensus kind of thing. It's like, let's come up with it. It was the same thing with like recommended oscillator settings back in the day. It was just an expert panel of people thought they were experts in that fields. I think it was just a guesstimation essentially, but saying, hey, if we're using higher FiO2, maybe we should adjust our PEEP a little bit.
The rumor I hear is that it was like decided amongst the Hopkins and University of Maryland crowd. It was just sort of like, if someone's on 100% of FiO2, what PEEP would you use? And I guess the expert panel came to the conclusion that we would do like 24 or 22 or whatever it is. So the point being, it's somehow like the least evidence based. I don't know if that's
Sort of arbitrary.
first move on.
Right.
Yes, it feels. I mean, it certainly feels arbitrary. So that's why, like, when you talk about choosing people, at least from my perspective, I think that anything other than that is better, right? Because if the table was like just opinion, then as an expert, theoretically, I guess that I am, like, I have the same amount of sort of leverage to say whatever I think is right. You know what I mean? Like, does that make sense?
Yeah,
The
yeah.
PEEP 502 table, I think, is sort of personally, I'll put my chips down and say it's sort of the worst way to choose PEEP.
I would
I've
agree
been
with
on.
that.
I think I've been on record saying that too, so it's sort of not.
I mean, I
different.
think we all would agree. Unfortunately, we don't have the evidence to back it, and it likely because too many studies just randomly assign a specific therapy to somebody that may not necessarily benefit from that therapy. When we get into some of the other ways to set PEEP, we can discuss the limitations of each study. For example, perfect example is like in terms of probably one of the more physiological methods to set is esophageal pressure. When they compared it against a low PEEP table, there seemed to be a trend towards better outcomes. Most of those patients had abdominal issues. It was only an 80 some odd patient study in New England Journal of Medicine. That was EP Event 1. EP Event 2 compared it to higher PEEP and found no difference between the two. But for example, setting PEEP according to esophageal pressure, you assume the lung recruits when you match your pleural pressure. And for patients that it doesn't, it may not be beneficial for them. So again, it's this random assignment, right? It's using a tool, but then not assessing the patient's response to it is really the problem with the RCTs is they're randomized to an arm that may not be beneficial for them. And we don't do anything outside of protocol. So you're going to get people.
Does
that
anyone here or in the chat use
Yeah.
the high PEEP table?
They did. So the last hospital I worked at, it was did up to the doctors to order high versus low. So on,
Like
for example, an obese patient, they would order the high PEEP table.
Okay,
Which
so
is
if they were
I
more
can't tell you
appropriate.
the last time that I used the table either way.
right, so I think that's sort of the now. Don't get me wrong, and my absolutes are I think balloons are helpful, certainly, definitely in the obese population for sure. I think they're helpful in a number of ways, but in the obese for sure. I think my issue with EPVEN 2 is that, as Tom pointed out, it was against the high PEEP table, and I haven't met anyone that uses the high PEEP table, so I'm not sure where to put EPVEN 2 in like the hierarchy of.
No, if you look
know
at
what I mean?
the
Yeah.
if you look at the lung safe data, most people use PEEPs less than 10 in patients that are on 70, 80% FiO2. So I agree with you. Outside of a study, the clinical, like the pragmatic or the reality of it all is that people don't use anything near what they compared to. So my argument always is, well, if you're never using a PEEP at 15 or greater, you may be surprised when you start using esophageal pressure that these patients may require higher levels of PEEP that you're just not comfortable with. And that's the beauty. Again, I'm not trying to promote one method over another, but that's the beauty of an esophageal balloon catheter. You put that in an obese patient and you see that they need a PEEP of 18 or 20, and then you jump both feet into the water and turn that PEEP up, and you realize compliance gets better, oxygenation gets better, like all these improvements happen. You're like, oh man, then you start thinking, how many patients was I scared to go to this level of PEEP simply because we never go to these levels of PEEP? So I agree with you. Even if the high PEEP table is there, most people, even if they protocolize it, like it was protocolized in our hospital, they would order it. But the minute you get to a patient who doesn't tolerate that, you know darn well you're swaying from this PEEP table, and most people aren't actually in the PEEP table, even though it may be part of their mechanical ventilation protocol. I'm curious in the chat while we're discussing if people in the chat can say whether or not the table is in their protocol for mechanical ventilation, whether it's a medical directive or a policy, whether or not they use the PEEP table, the PEEP FiO2 tables in the protocol. I'll say
You also
yes
mentioned,
for two hospitals I've been at, two hospitals I've worked at, they were, and the rest of them no.
Yeah, no for us. And you mentioned lung safe, which is almost 10 years ago now, or it is 10 years ago, I think. I wonder if we're better at it now. Do you think? We got to be, right?
I think we're better at proning. I would probably argue we're better at. I would probably say we're better at. I would hope we're better at proning after COVID, because proning was really low in the lung safe study, despite patients meeting the criteria. I hope we've improved from there, although I wouldn't be surprised if people fall back into old habits where they don't do it when they should. The same thing when SARS 1 happened. I worked in Toronto. We had SARS patients. PPE was all the thing. Bronx were done with PAPR hoods, et cetera. And then as the further along you get from that event, people start forgetting to put masks on, forgetting to do this. Next thing you know, you're intubating with no mask. And like, it's mind blowing how we just forget the farther away we get from it. So my fear post COVID was that people were going to forget the value of proning patients and hopefully not slip back to where they were pre-COVID with the lung safe data.
I wonder if we're better at checking plateau pressures, because you remember we sucked at that, but we looked at the lung safe too. I mean,
A lot of hospitals, and maybe you guys can comment, I feel like a lot of hospitals have added it if they weren't documenting it or if it wasn't a specific spot, for example, for either plateau or driving pressure. I think there's a trend towards people starting to pay more attention to that.
It's part of our EMR.
Excellent. I mean, 10 years after the fact, right? Amato's
Sure.
paper sort of bringing us to, hey, maybe we should pay closer attention to this. I think, 10 years later, I think more people are starting to use it as a monitoring tool in their documentation. But I think it took a long time, just to convince people, hey, can we start doing plateau pressures again? I feel like back in the day, that's what you did to do all your measurements.
Yeah. Everybody used to have the watch with the little calculator on it. And cashier watch it.
And a
And a fanny
pencil, too.
pack.
I mean, I still used a fanny pack right up until I left the bedside.
With the oxygen wrench and a couple of Christmas
Couldn't
trees.
help.
There you go.
Yeah, a couple of PEEP valves.
I picked this
a
guy
couple
up
extra set
yesterday.
of gloves.
A prime example of this. He's 70 inches and 159 kgs, and picked him up on 16 a PEEP and 80%. And I brought him back to our place, and the RT was just shocked. 16 a PEEP, what? And I was like, he's probably under PEEPed.
Yeah. Sure.
So
What is that, like a 70 BMI without looking at it?
I don't know. Yeah, it was 358 pounds, I think.
Yeah, it's shocking to many people who have not seen PEEPs that high. Sorry, Danielle, you're going to say
I
something.
was going to say that, I mean, the highest PEEP I've ever extubated on is 37 a PEEP, and that is a 700-pound patient.
Go.
That's also with using esophageal manometry, as well as understanding that that patient has nothing wrong with their lungs at that time anymore. It's just the chest wall and belly. And I think
And
that's
likely you extubate to something like CPAP, right? Like it's not just a jump in.
to CPAP. And we did that for about an hour to an hour and a half. And then we transitioned the patient off. And they never ended up requiring a tracheostomy too, because that's what we were looking at. They actually got them in with nutrition. And then now with all the GLP-1s and everything, they didn't come back in. But we used
I
to
wonder
have
if anybody,
patients with that. So we typically do run and we utilize esophageal manometry a lot in our institution, but also in North Carolina, we love our fried food. We love our so we have a higher morbidly obese population that also have history of obstructive lung disease. So do with that with what you will, because it is interesting to ventilate those patients and be able to separate the two as well.
yeah, it's important for the whole team to understand why you're on the PEEP that you're on and your strategy of, regarding using the higher PEEP, even though the patient doesn't have a intrapulmonary problem. I wonder if anybody would have trached that patient on 37 a PEEP. Like nobody will get near anybody that's on.
They will not, just like they will not trach anyone on the mode I utilize here. So.
The mode you utilize there, is it just the alphabets?
She's purposely being vague.
Very cryptic.
Yeah.
APRV will all say it.
Yeah,
I
there we go.
know.
We said it for you.
TCAV, I know you're.
This is a dangerous audience. She's like, this is a dangerous audience for me.
Did you see that? Andy, do you use the PEEP table?
Yeah, I mean, so here's the thing, right? Like, and as an educator, as the practicing day by day educator of this group, both in the classroom and and at the bedside, I will say that the value of the PEEP table is I can get them off of a PEEP of 5 immediately. Like if I'm turning their oxygen up. From there, do I need to do further assessment and end up somewhere else? Probably. But at the very least, if somebody's not there that understands lung mechanics well enough to make some of those decisions, at least I'm not on a PEEP of 5 and 100%. And as a tertiary care facility, we get patients from hundreds of miles away. And when you get a patient day 4 of ARDS, it's been on a PEEP of 5 all 4 days, and because that facility didn't utilize anything and were very PEEP phobic or what have you, if at least they would utilize the table, they could have been on 10 or something more than 5, so that we didn't lose all of their lung by the time they get to us. From a training perspective, it's nice. And from a standpoint of, if we, work with these outside hospitals, like, look, just use the table. That way you don't have to have a deep understanding of lung mechanics if your staff isn't there. At least you can get them off of PEEPA 5. So it's baked into our protocol, but I will say from a competency standpoint, we drill our staff pretty hard about, hey, start here and then make an adjustment if you need to get to a more therapeutic PEEP based on some of the other things I know we're going to talk about moving forward here.
Yeah, and I just wanted to put up on the screen, like for any, even when people may have it protocolized, this is the data from the lung safe study that we mentioned earlier, and you can see right up until it's not until 80% that the average people level used in patients, and this is a study of 50 countries and over like 500 ICUs. The average PEEP on an FO2 of 80 was 10, which again, if you're using the low PEEP table, you're not at 10. You're at what, like 16, 18 by that point, or is it 18 to 20? Anyways, bottom line is like, but I think we don't want to discredit people who use the PEEP table. It is definitely a decent starting point. It tells you if you're on 50% FiO2, you probably shouldn't be on a PEEP of 5. Like this is the utility of it, the usefulness of it. But where you go from there really depends on patient response, respiratory mechanics, their body habitus. All of those things play a role into whether or not whatever you choose is effective, whether or not there's airway closure present. Like all of these things play a factor in it. So, is it a starting point? Sure. Are people hesitant to do anything above that? I mean, the data speaks for itself. Most people are hesitant. And unfortunately, there's not a one solution for that because not everybody has esophageal pressure like Danielle. He says you use it a lot. Some people never use it at all, right? So hence we're going to talk about other methods for setting PEEP. Many of them may involve things that you don't have in your ICU, unfortunately. But this is the reality of where we're at.
That's a good point, Andy, about the PEEP-FiO2 table. Something I guess I haven't put a ton of thought into.
I have a question. Like, especially with the PEEP FiO2 table, like, where do you fit in the tidal volume in that scenario, right? Because like the way that I think about it is that you have really less than 30, right? Like 28 centimeters of water to fit into the chest, right? So if you intubate someone and they're on a 7 cc breath and their plateau pressure is already 28 or like 22 or something, right? Then you have to add PEEP into that. And if they're on 80% and you're going to go to 16 to PEEP, well, you add those two numbers together and you're going to be over 28. Now that sort of gets into this idea of like recruitment, because as you recruit lung, you sort of spread that total volume over more area. But like, how do you negotiate that in the beginning? Let's say when you're starting, like if someone's like freshly intubated, let's say, and they're hypoxic and they're on 100%, and like we crank the PEEP because the PEEP FiO2 table tells us if they're on 80% to go to 16. But where does the total volume sort of fit into that, or how do you like negotiate those two?
Well, essentially, it depends on what you prioritize. If you prioritize plateau pressure versus driving pressure, right? I think this will come down to that as well, because you can have a starting PEEP level, but then you want to immediately assess the safety of the tidal volume that you've selected going into the lungs. And you're right, if someone has a baby lung and non-recruitable lung units, if you choose any higher level of PEEP, you're going to end up with, again, sometimes not even a plateau pressure that's concerning, but a driving pressure that certainly could be. And then just determining, is that driving pressure due to the stiffness of the lung, or is there airway closure? Like there's so many things we should probably do to determine that the driving pressure is actually the driving pressure before we start lowering tidal volumes and lowering PEEPs to try and fix these things. For those who don't use a table, like I found this when I was doing a talk once, and I had heard it before, but couldn't remember the numbers, but people refer to something called the Gattinoni method, where he was like, if you have ARDS and it's mild, starting 5 to 10 is a reasonable starting point for PEEP. And then for moderate ARDS, it was 10 to 15. And then for severe ARDS, it was 15 to 20, with preferences starting at the lower one to assess immediately the response to it. So I think your point is well made, Nick, that if you start at a PEEP of 15 because someone has severe ARDS and they're at 80%, you start at 15, but now your driving pressure is 20. The first thing you're going to do is determine, okay, what happens to that driving pressure if I turn down the PEEP rather than turning down the volume? Because if the PEEP is not useful, then it probably should be turned down. How many of you, and in the audience maybe as well, how many of you prioritize plateau pressure or driving pressure? So if we had to take a vote in the chat, plateau pressure or driving pressure, what would you consider the thing to worry you about the tidal volume you're using at a certain PEEP level?
Yeah, if you'd asked me this question while we wait for responders, if you'd asked me this question 20 years ago, I would have said without a doubt, freshly introduced to the ARMA trial, I would have said plateau pressure.
Yeah, of course.
But today, I think that I pay a lot more attention to, given the information that Danielle talked to us about, morbidly obese patients will have a much higher plateau pressure than somebody who's not. I just, yeah, I pay a lot closer attention to driving pressure, and I have a pretty hard and fast rule that I do something different if somebody's if somebody's driving pressure is going to be above 15.
Yeah. John, what about in the transport world? Because I know like you guys generally
Mhm.
have patients for shorter periods of time than the ICU might have. Like when you pick them up, are you, concerning yourself with those values and trying to do anything in particular to see if they
Yeah,
can be
and
reduced
and
or
to dovetail on what Nick said, 80% and 16 a peep, and he's right. I mean, our guy yesterday, volumes were closer to 6 mLs per kg, and the plateau was 31, the peak was 35. So I was right there at my driving pressure of 15, which is what we wanted. But no, I try and pay attention to that. I try and optimize the patient. So when I do deliver them to the facility that we're going to, that they are optimized. Which is funny. Yesterday when I dropped them off to the ICU, and the therapist was like 16 a peep, her head exploded, and I was like, "Do we not understand that this guy is, like I said, probably under peeped?" I have to use on my device. I have to use PV curves. I don't have esophageal manometry, obviously, on my transport vent, and some of these other smaller facilities aren't. They just don't do esophageal manometry. So
right. At least driving pressure is something that you can look at. I mean, some transport vents don't allow you to do inspiratory pauses, which can be a little challenging as well. You can manipulate eye time to get a plateau pressure, but it's not ideal
it's kind of a
to not
backdoor
have it
way
usually.
to do it.
Exactly. It's like, how can I get a plateau? Well, I can make sure flow
Right.
reaches 0.
Yeah. So, and Mr. Hilton's joined, so he might be able to add on to the transport stuff. But I try and optimize them the best I can, and then I do pay, like Keith has said, I pay more attention now to driving pressure.
Nick,
How
how
about
about you?
how about
Oh,
you?
sorry. What do I do? Is that what you're asking?
Are you
Yeah.
prioritizing plateau or driving pressure in most patients when
Oh,
if
yeah,
you
that's a good
if
question.
you're
So
changing PEEP,
I
what are you paying attention to?
yeah, so this is the meta point about driving pressure. The fastest way to make driving pressure better is to drop the volume, right? Because it's like mathematical. To John's my I have a like the question I'll ask John is, what's your pH there? Like on those on like 6 cc's per kg, 16 to peak, 80%, your plateau is 31. If you can go to 5, like if you have the pH and to go to 5, like if your pH is 730, right? And they're tolerating it, they're not like hemodynamically unstable, et cetera. ARMA, and ARMA is what it is, but tells us we go to somewhere like 7.2, this permissive hypercapnia situation that you guys all know about. So for what I do to answer your question is if I intubate someone, and they're in ARDS, let's say they have pneumonia, whatever, I pick sort of a middle of the road total volume, maybe like 7 cc's per kg. And I sort of get this like stable-ish gas. And I try to figure out what's their acid base situation because that is going to be the sort of like the rate limiting step to dropping the volume. And if I can drop the volume, I can increase the PEEP. And if I can increase the PEEP, that's like sort of the name of the game to get recruitment. You know what I mean? So I don't know if I prioritize Eric, who isn't here unfortunately, but the way that we sort of did it was during COVID running around, sort of everyone is in ARDS. We would sort of start with we would build a table based on some volume, 7 cc's, 6 cc's, whatever it is, and then figure out what's your plateau, what you're driving, like what's your plateau, what's your peak, what you're driving. And then whatever sort of mixture of those three gave you the best, that's what sort of we would pick. So, we called it like our sort of like PEEP titration table. So I do manipulate the plateau to get a better driving pressure. So a short answer, I give you a long answer to a simple question, which is I do prioritize the driving pressure. But the thing that makes me nuts is I think there's this like undercurrent that there's like some driving pressure button on the ventilator. Like just go make the driving pressure less than 15. Like you need to do other things to make that happen, right? You need to drop the volume. You need to like not over peep. You need to not under peep. To Tom's point, especially if you have like an obese patient, there is just like sepsis. Like there's no make sepsis better button. There's no driving pressure less than 15 button. If there was, and we probably wouldn't be having this talk. But um, yeah.
Yeah,
Does that
I
answer your
think
question?
I think my comment was more like in terms of prioritizing. I think what I'm really trying to get is that when you make a change on the ventilator, for example, if I increase PEEP, my plateau is going to go up by the amount that I increase my PEEP. That's just how pressure works, right?
If you're on the straight part of the of your
Correct,
PV
correct.
curve.
Yeah.
Yeah,
So
right. That's so that
yes. So my point is that your if your PEEP goes up, your driving pressure is staying the same. If my driving pressure is staying the same, I'm not overly concerned about where my plateau pressure is at because I'm still linear. But when the driving pressure changes after I increase PEEP, I need to ask myself, well, I might be going in the wrong direction. If I
right.
just put a patient on the ventilator, let's say I put a patient on a PEEP of 8, this is a true story. A patient came in post cardiac arrest. They came in from out of hospital, PEEP of 8, high FiO2. Paramedics were worried about using higher than PEEP of 8, and I'm okay with that. That's reasonable. My driving pressure, my plateau was 28 with 6 mils per kilo. So I'm like a driving pressure of 20. And I'm like, this seems like a really high driving pressure for someone who just came in. My threshold, my immediate response was to check for airway closure. And this patient's inflection point was 16 centimeters of water. So I immediately turned the PEEP up to 16. And guess what? My plateau didn't change, but my driving pressure is now 12 instead of 20. So clearly that pressure was just wasted pressure, but it made you think like, oh my God, if you didn't think that way, you might think, oh my goodness, 6 mils per kilo of predicted body weight and my driving pressure is 20. My plateau is safe at 28. But if you focus on driving pressure, you might think, do I need to decrease my tidal volume? When the answer really is we need to do more things to determine whether or not they're just completely under peak. And the same situation would happen in an obese patient. If the lungs open up with the pressure you're delivering, the plateau pressure is the pressure required to keep the volume in there. But when you exhale, the amount of driving pressure depends on whether or not your PEEP is appropriate. Yeah. I think most of us would agree that if we're increasing PEEP and we're in the linear part of the pressure volume curve, we shouldn't see a huge change in driving pressure. But that should be a red flag if you increase PEEP and your driving pressure goes up by 5 or 6 or something like that. If you're decreasing PEEP and your driving pressure goes up, you could argue could be collapse, but it could just be that you're below airway closures. We need to be aware of those things. All right. For the essence of time, should we move on to another slide there, Keith? What do you think? We skip pressure volumes. I kind of just briefly mentioned this now, but
Yeah, we should maybe pull up a couple of these things.
a couple of the
Damien,
questions.
if we think that our patient needs 16 centimeters of water of PEEP and with 6 milliliters per kilogram as plateau pressure 28, I would reduce tidal volume less than 6. What do you think? Yeah,
I would not if the plateau is 28. That's a driving pressure of 12 and the patient needs 16. I wouldn't go lower on the tidal volume for that patient.
Right.
Because then you start getting into, as Nick mentioned, you will get into acidosis problems when you start using 4 mil. If you keep going down, you're just going to make gas exchange harder when you could argue that it's not a safety concern at this moment, even with plateau of 28. If the patient needs 16 and your resulting driving pressure is 12, I would argue that it's probably not unsafe to ventilate this patient at this time at this level. Like I wouldn't start chasing the lowest possible driving pressure or the lowest possible plateau.
So our guy yesterday was 7.17 with a CO2 of 78.
So there you go. So now, so that's what I mean. So now you have a problem, right? Because you can't, and then so I don't know what your rate is. Then you have to, theoretically,
26.
a lot of 26. Yeah. So then most patients, and all obviously everyone's got like COPD. So there's like this heterogeneous like mixture of like probably obstructed lung units and whatever. But like you're kind of stuck, right? In some ways because you're sort of you can't really go up on the PEEP because unless you think you're sort of recruitable in some degree, um, you can't drop the volume anymore because you're already at 717. And I get certainly squeamish when I get under 7.2, right? Like that's like sort of my soft stop. So that's when are you at your max? Like, can you maybe go up on the rate a bit to like 28? But then you have to worry about, are you going to start to sort of auto peep? Theoretically, you shouldn't if it's like sort of pure ARDS because like their compliance is so low. But there's a lot of patients that I see, certainly when I was working in Baltimore, that had really bad ARDS, but also had COPD on top of it. So you're really stuck because they need this like sort of bigger minute ventilation because of all this dead space from their COPD, but also the ARDS. But then you get into like this auto peep situation. So I don't know, man. It's like a tough spot to be in with the vent. I feel like at some point that's what I'm saying. We might not always be able to get driving pressure less than 15, right? There's no button to just press and then it happens. Like you're sort of stuck with the mechanics that you have. So
Yeah, if you have a patient with infra-abdominal compartment syndrome, you're not going to get driving pressures very low. And this is where esophageal pressure can tell you that, oh, the patient's not feeling all of this pressure. This is where distending pressure becomes useful if you have it. In a transport scenario, you're really just going by like, is it safer to give this person higher tidal volume? Yeah. Is everyone a volume control user? You put it on a screen, you can just ask Danielle. She's right here.
Yeah, I'm
don't
right here.
ask everybody
Well,
else.
the reason why I asked that is just because, like, reading her question, going back to the last question, it's more of like, is she a volume control user? Like, is she a pressure control user? Because otherwise, like, yes, her peak and her plateau, like, that might change as her patients get worse. That's why I was trying to understand, just because to me, it wasn't unsafe. It wasn't an unsafe question as far as like her driving pressure with that.
So I'm gonna ask this question of Nick because I'm sure that people are going to disagree.
Right.
Maybe there is a button, a driving pressure button. If I put somebody on pressure control ventilation and I set the driving pressure at 15, and a patient that's not breathing, Tom, before you get riled up about it,
I'm not going to say anything.
that's not breathing, haven't I pushed the driving pressure at 15 button?
If your flow goes to 0 at the end, then yeah.
But if it doesn't,
depends
it's
on-
likely lower
Yeah,
than
that's the
15.
most beautiful
Yeah.
question.
But if they're
Okay.
not breathing,
Yeah.
it wouldn't be higher than that.
Right. Okay.
I mean, it's gonna depend on their compliance, right? Like, and so if you put them on a PEEP of 10 and a delta P of 15, and they're completely passive or paralyzed or whatever, yeah, your driving pressure is 15, but you don't like what's gonna be what is the unfixed variable? The unfixed variable is the volume. So if you get a volume of 200, that's like, what are you doing with that? You know what I mean? So you can, and this definitely gets into the transport world, especially with the T1, because like Melody, who is sort of my partner in crime in some ventilator stuff. I guess the T1 doesn't have a hold button, like an end inspiratory hold button, so you can't get a true plateau pressure. So you're sort of like reading the flow curves. So even if they're on a delta P of 15, and we say the driving pressure is 15, which is also a confusing term because I think we in pressure control we call like the inspiratory pressure the driving pressure, but it's like not sort of the same.
It's dynamic. Yeah, it's the
That's what we
dynamic
mean.
driving
Yeah.
pressure.
But no, it depends on what your flow curve is doing. If your flow curve is, and this is like, I mean, like a daily occurrence. I've had many a physician tell me that pressure control is better because you can control the plateau pressure won't be higher than what you set. And then I look at the ventilator and the flow curve is like kicked out and they're pulling a liter. And I'm like, I don't know about that. It doesn't matter like what the delta P is because the flow is unfixed, right? So they can pull as much flow and volume as they want. And you don't, if you can't get it sort of a hold, like you don't know what the plateau pressure is. So
Yeah, that's
like,
for spontaneous breathing. Yeah, for sure.
that's often
You have
that's often a
the
point of
true driving pressure.
contention, especially with like, maybe inconsistent ventilator users. And that's something that sort of goes, it's a key point, but I think it's sort of misunderstood in some ways. So
someone says under tools. I don't think the transport vent has this, right? Is this on the
It does not.
No. So we're talking about specifically the T1 transport vent. And most people using it say there is
there's
not
no
an inspiratory
there's
process.
no floating valve or something, or there's no valve.
There's no inspiratory valve, so it
It's a
can't do an
floating valve.
inspiratory hold.
It's a floating something or other is what I'm told. I don't know what that means.
Joe, what do you know about the T1, man?
There's no inspiratory valve, so it cannot do an inspiratory hold.
Okay.
Cannot.
Why
All
is
you
that?
do space and weight.
Yeah. Okay.
This person says they used it last night on the T1 transport vent. I don't know what software they're using on it, but
No, it doesn't matter. Trust me, I work for the company. I know. There is a button that you can press that will prolong the eye time to whatever pressure you're delivering, but that is not an inspiratory hold. It is not.
Well,
It is not a closed system.
can you just put a button on there that says inspiratory hold just to make us happy?
You can put
It
one
doesn't
on
actually
just
have to
whatever
do
you want.
anything.
Garbage in, garbage out.
Or driving pressure 15 button.
There is a driving pressure calculated on monitoring page 3. They can go to and find it.
Ooh,
all right.
Okay. All right.
Should we?
Yeah, we should. Or else we're going to have part 2 and 3 coming up.
Yeah, we can quickly go through PV curves. Again, if you have the availability on your ventilator, then you can do a slow flow inflation curve. If you don't, you can utilize you can use volume control and do a pressure time curve. I had a draft Instagram post for like 2 weeks that I just posted last night because somebody actually emailed me and asked me a specific question. And I'm like, you know what's funny? I got something in drafts that answers that question. And I sent it to them. Like I downloaded the video and sent it to them. And then they replied and said, you should post it. I'm like, okay, fine, I'll post it. So anyways, pressure volume curves traditionally have been what most people agree now have been misinterpreted. So what I say by that is at a lower inflection point, when you have a lower inflection point, this creates a hysteresis between the inspiratory and expiratory part of a pressure volume curve. However, that inflection point, more and more people are saying that this represents airway closure, not recruitment. There was a study in 2001 that showed that PEEP levels above the lower inflection point all had de-recruited volume when you decrease PEEP. So it didn't reflect recruitment. And then more recent studies, now that we have EIT, you can see when as the pressure is changing, there's no change in volume within the lungs until certain areas. When you have a very abrupt one, you have airway closure that may be more diffuse through the lung and close throughout the lung. So the areas that have airway closure are closely related. When you have a progressive, like a more mild inflection, you have more dispersed airway closure, more differences regionally, and those differences could be 3 centimeters of water from the average to the highest airway closure. Now, does that change how you use it to set PEEP? Absolutely not, right? If you have a lower inflection point, what it's telling you is it's the lowest level of PEEP you probably should utilize. But it doesn't imply that that's the level that has the optimal recruitment. That's something that would likely be above that. So that's so far what the evidence is showing, that the lower inflection point is still a point that you can set PEEP at. But even here where it says set 2 above that, your regional airway closure could be higher than that. Or it could be higher than that. It could be even more higher than that. The bottom line is it's a starting point. It's useful. I'm not saying it's not useful, but it doesn't reflect recruitment as people originally reported. And I can give links to studies on that if anybody wants. In my Instagram post, I posted a few different references for that. But
Yeah, some ventilators do this for you, right? They have a button.
yeah, no, it's very nice. They have there's the PV tool, and I will point out that different ventilators do it differently. The Drager does it slow flow inflation. The Hamilton ventilator does it in pressure increments. So I personally would recommend, if you're using the Hamilton, to use the smallest jump in pressure. It will give you the most accurate inflection point, simply because it's not jumping up and you're like, did it jump up at, like where was the inflection point? And if the difference is 3, it might, again, it's going to throw you off. It's not going to be so off, but I would use the lowest, I think is 2 centimeters of water per second. I would use that if you're going to use the Hamilton vent. And then otherwise, if you're using the Drager vent, use 5 liters per minute of flow. If you don't have a pressure volume curve on your ventilator, you can still get a pressure time curve, which shows you an inflection. And you can use that by simply using volume assist control with a flow of 5, a PEEP of 5, a rate of 5. You get a nice inflection point. We don't have time to demonstrate that now, but it's very easy. You can go to my calculator if you want, and there's videos on how to do that. I'll put my calculator in the chat if people aren't aware of it. Should we move on? Does anybody want to add to this one? And then I'll stop talking.
I'll just say, as a Hamilton user, just to add to this, it only works if they're not taking breaths, right? They have to be pretty much paralyzed. So a lot of times we'll just do this like immediately post intubation while the paralytic is still on board from the intubation, just to get a baseline. But I agree with everything Tom said about you want to see linearly right where it's at, right? You don't want to miss it by 2 centimeters of water because you made the jump too big, just to shave off your time. To do it right, it takes about 35-ish seconds. So you also have to make sure the patient can hemodynamically tolerate that. Sometimes when we intubate them, they're not, strictly speaking, super stable. So if they're not, they may not tolerate that whole 35 or 7 seconds of that maneuver but if they can tolerate it, it does give you some nice information if you have it set correctly.
Yeah, I definitely don't want to make it sound like I'm poo-pooing it. I'm just saying, like, for those who traditionally, like, it used to be said, oh, this is the point that the alveoli open. There's more and more studies showing that the alveoli aren't completely collapsed where that inflection point is, and that it's airway closure, but it's still telling you to do the same thing. Set your PEEP at minimum here. But you may not want to stop there. If nothing's changing with the patient, you may need higher PEEP. It's possible if they tolerate it. But recruitment is something different above that level.
All right, what's next on deck?
Got decremental.
What do you know about that?
I mean, I know lots, but I'm talking a lot, so I'm gonna stop right now.
Anybody use this method on the panel? Anybody used to use it?
I can chime in and give you a nutshell on it.
Yeah, give us a nutshell.
I think it's very valuable for someone that has the time to do it and the patience to do it. It's very time consuming from a stepwise fashion. But can it be useful? Yes, very much so. But I think in today's age of things, we'll see a lot of people, once you get past about step 4 or 5, you've lost interest and you're involved in this.
Go ahead, John.
We used it at a previous hospital when I worked out of state and up in Cincinnati. And this was, I don't know, 2009, 2010. But we did it in the cardiothoracic unit, and we did it for patients that came out with lower PF ratios. And long story short, people were getting dinged for long extubation times. Surgeons were looking at nurses were looking at us. And obviously these surgeons wanted 10 to 12 mLs per kg ideal body weight, tidal volumes. We said, no way, we're not doing that. But they would come out with atelectasis and low PF ratios and such. And so what we developed was...
And PEEP of 0 in the OR.
Right. So we came up with a decremental ladder that we put them in pressure control. We'd increase them up to 20 and then we would decrease it by 2 and then get a gas when we got to 8. and we got the extubation times down. We had better efficiency with our patients when it came to PF ratios and pleural effusions and atelectasis and all that thing. Obviously, there were things you wanted to look at in the cardiothoracic unit, you chest tubes and bleeding and other issues, but it seemed to work.
So, John,
As
are you saying you use it as a way to recruit and then left them on a PEEP at 8, or did you determine an optimal PEEP in that range?
well, no, I mean, yes, is the answer is yes. We would go up to the 20, and then we would slowly decrease them, and then we would stop at 8 was the number that we had. But that's the problem with other decremental ladders is that you don't know where the optimal is. If you do 30 for 30 or 40 for 40, and then you come back down to a PEEP at 12, what do we do? What are we doing?
Yeah, the decremental PEEP. Sorry, go ahead, Andy. I don't want to keep.
Yeah, Tom, I was just gonna say, like I agree with Joe. This can be very useful, and it's kind of a combination, right? It's a can be a mini recruitment maneuver. You don't have to go all the way up to 40, but you go up to 25. But then I think you come down the opposite way from what you described from the lower inflection point, right? You're just trying to get below the upper inflection point.
That's
I think so. You can kind of determine at least a version of the best PEEP that way, right? Because you basically come down until your plateau drops by more than what you drop the PEEP by, right? Like, you get into that flat part of the PV curve as you come down slowly. So then you find a place where you're not over distended. You're obviously recruited if you're in the linear part of the curve because you're above the lower inflection point. So I think you've done a mini recruitment maneuver. You've hopefully opened some of the alveoli that you may not have, and then as you come down, if you stop at that point where you're below the upper inflection point, you can land at a good spot where you have, kept the recruitment that you gained.
Yeah.
So, John, the reason for stopping at 8 in your modified hybrid decremental PEEP titration was to not delay extubation. I mean, not necessarily because it was the right
Yeah, it
amount of
sounded to
PEEP.
me like it was more like a recruitment strategy.
Yeah.
Increase the
Recruitment
PEEP and then
strategy
slowly come
because
down. And
we weren't going to do 10 to 12 mLs of tidal volume, which is what these surgeons wanted. So this is what we came up with: the 6 to 8 mLs per kg, obviously lung protective, and then using this hybrid decremental ladder to, yes, I mean, essentially to get them off the vent and to help. They weren't getting off the vent because they were still low PO2s, and it was probably because they were underutilizing things. So that's what we came up with. That's what worked for the surrogate that we were looking for, and that was extubation.
And Tom, I'm sure you're aware, Kazmarek published on this sometime in the mid 2000s, where he, put him in pressure control, turned him up to, I think it was a total pressure of 50, and then
yeah, so
15.
essentially, yeah, so
Go ahead.
that study was stopped early due to futility. They weren't getting the numbers they wanted. The difference wasn't significant. The second attempt at that trial was the ART trial, which had a more aggressive recruitment strategy and ended up with increased harm. So this is one of the reasons why, the decremental PEEP trial may not have been the problem. It could have been the recruitment strategy. It could be that for patients who aren't recruitable during the decremental PEEP trial, you are at higher levels of PEEP for a prolonged period of time, which could be injurious to the lung. There's a lot of unanswered questions. I wrote a protocol for decremental PEEP trial at a previous hospital I worked at years ago based on the maximum recruitment strategy published by Marcelo Amato and his colleagues. That kind of was the protocol design for the ART trial. I personally feel now that decremental PEEP trials, this is maybe controversial, but should be limited to using with EIT for determining the crossing point. The reason why I say this is that the more we utilized EIT over the years, we realized that best compliance doesn't always reflect what we think it does. So, for example, while you're doing a decremental PEEP trial, and for anyone who's done it, you may get a couple of PEEP levels where compliance really isn't changing. And when that's happening, you're starting to have a trade-off between overdistension and collapse, right? So your collapse might be going up, but your overdistension is going down, and your compliance is just the balance of those two things shifting. So what can happen is at higher levels of compliance, regional respiratory system compliance, you can have a significant amount of collapse. So that's when your collapse starts to go up. So even though it looks like you're really compliant, you can still have tidal recruitment that reflects good overall respiratory system compliance, but you may have collapse happening at end exhalation. And there's recent animal data looking at EIT to try to determine, is the crossing point between overdistension and collapse where we should set PEEP, or should we avoid overdistension entirely, or should we avoid more of the collapse? And so far, they're finding that the collapse is actually worse than I would have thought the opposite, but the collapse is turning out to be worse than the overdistension. Keeping in mind, we're not talking about maximum overdistension. We're talking at the point where it starts to cross, you can usually get a little bit less overdistension going one way or a little bit less collapse going the other way with your PEEP. And they found that if you allow more collapse, you actually have more cardiovascular issues. So we still don't, we think the crossing point's the best, but the bottom line is the compliance doesn't tell you that your lung is not collapsing. And that's what we're learning with EIT, having both, because the Timpel device that's available in the US gives you respiratory system compliance and collapse and overdistension. And when you look at this data, you see a lot of the time, you see that compliance is continuing to climb as your collapse is getting significantly worse. So if you're just using decremental, it might be better than nothing. I'm not saying don't use it, but don't be convinced that you got to get the best compliance or the absolute lowest driving pressure is really not the goal here, because you may be having collapse that could be causing lung injury over time. We still need to learn a lot about it, which we have since we have EIT. We're realizing decremental. We understand now why the studies maybe haven't been as impressive as we were hoping they would be, basically on the data that we're learning with EIT.
Has volumetric CO2 been looked at as a surrogate for that as well, to maybe teasing some of that out?
Yeah, I mean the Servo U has this open lung tool that for years had done, basically you do a decremental PEEP trial and it would trend VCO like volumetric capnography and compliance, etc. It's definitely helpful when you have collapse. Again, if your lung is open, if you have tidal recruitment, it may not reflect negatively in the volumetric capnography. But I haven't seen specifically EIT with compliance and volumetric capnography. I'm sure someone has it out there, but I haven't looked specifically at that. But it's definitely added benefit. Like I actually really enjoy volumetric capnography as a monitoring tool. It's fantastic, particularly when you're making strange rate adjustments in someone with auto PEEP. Like when you're decreasing rate, for example, because someone is air trapping, and then you see volumetric capnography going up despite minute ventilation going down. This is like a really great teaching tool at the bedside for sure.
Cat's meow.
Yeah. All right. I'm going to shut up now. Danielle, you're up. We got 7 minutes.
We got 7 minutes.
We already talked about
we're
mostly
already
driving
done.
pressure, so we'll get here. There we go.
So for esophageal manometry, we utilize it for, obviously for the most part for our morbidly obese population. I'm not going to say that we always use it for that population, but we also teach, we utilize it for different contexts at my hospital. So we can utilize it as a tool for, seeing is what we're actually capturing on the ventilator. Are we going to confirm that that is that patient's optimal PEEP? And that's typically what we do in that population. But you also have to consider, so the cons, yes, it's invasive. Yes, it requires specialized equipment. But also, if somebody has an intrapulmonary issue, that's not going to be the PEEP that that patient needs at that time. So if I have a 600-pound patient and maybe their optimal PEEP is 24, if I put them on that 24 PEEP, they're not going to do so well. And I know that. So we go and we have where we teach our therapists that end up holding competency. We don't just have them performing actually placing the esophageal balloon, but how to interpret that as well. So we just utilize our PEEP to keep our transpulmonary set typically not above like the 10. I will say that someone mentioned in the chat that they don't have access to esophageal manometry and they don't have access to EIT. So when I think that we kind of, yes, it's great to talk about these things, but a lot of the people that might be on, they might not have access to that. So what would be the best for them to utilize as well? So I wanted to kind of get everyone's thoughts in the group on that, because that's key. In my area, for example, yes, for the large level 1 trauma center, we have a lot of hospitals where the people come to us. They don't have esophageal manometry. And in fact, they are using C1s and T1s. Some of them still have, like, they're using pure to minute out here, not our hospitals, but other hospitals. So it's kind of like that they might not have access to some of these things that we might be talking about. So I just didn't know what everyone's doing. What do you recommend in those types of situations?
One thing that's an option, you kind of get into the thing of becoming a lot of steps again. I know Keith has done this. Pretty sure John has. I'm sure Tom has too. You can take an esophageal catheter and you can transduce it with an art line. So you're able to get a pressure up on a monitor. Now, the trouble comes into play when you're having to make sure that your monitors are giving you the same centimeters of water pressure your vent is. And when you're doing maneuvers, you've got to really pay attention. So is it kind of an OCD maneuver? Yeah, it sure is. Because it's how the simplest.
I mean, my online calculator defaults to millimeters of mercury because that's how, when I built that calculator, we were using ICU monitors for transpulmonary pressure. It defaults to millimeters of mercury. So if you're using a vent, you'd have to change it to centimeters of water, but that's exactly why. So yeah, we had Avia ventilators, but then we got a whole fleet of Drager and we had servos and we weren't using the Avias anymore. So we had a standalone catheter and just used the ICU monitors. So it's not useful for things like asynchrony, But for determining what your pleural pressure is during passive ventilation, it was, and even pleural pressure swings you could look at during active, but you can't monitor asynchrony if you don't have it on your ventilator with your waveforms. But in terms of seeing your pleural pressure, yeah, it works fine.
And does that work for every monitor though? Because I know for us, like we have Ehon coding, and we
if
have
you can monitor arterial pressure, you can monitor esophageal.
and it for some reason like I could never get it to work properly.
If you can monitor arterial pressure, you can monitor esophageal pressure.
Yeah, you just use a
You-
disposable transducer
You're using the same
bedside
transducer.
monitor.
Yeah, you don't got to get a water bag or anything. You don't have to do anything.
Yeah.
You're just using the transducer hooked directly up
Yeah.
to it.
That's it.
Yeah,
For
first 100 balloons I put in, I probably did that before we got a ventilator that could.
Yeah, like I've been very fortunate most of my career to have fancy tools and fancy gadgets like esophageal pressure. When EIT came available in Canada in 2013, we were the first hospital to have it for clinical use. So I've been using this stuff for a long time. During COVID, I moved to a different city and I went back to the bedside during the pandemic, and I didn't have access to. I mean, we had esophageal catheters there, but they were locked in the charge therapist's office. So even though the charge therapist's protocol was based on the protocol that I sent them years ago, we didn't have access as bedside staff. We had to go find the key and blah, blah, blah. So I didn't utilize a lot of the fancy stuff, but I can tell you every time I received a patient, I did two things immediately, which again requires training and techniques, but it does not require fancy gear. First thing I would check for was airway closure. I want to make, again, this is that lower inflection point. So if you don't have a PV tool, it doesn't matter. You can still check it using volume assist control. So I would check for airway closure, and then I would do a recruitment to inflation ratio. Those two things. Why did I do airway closure? We already discussed. It's like the lowest level of PEEP I would set it at. Why did I do recruitment to inflation ratio? To see the likelihood that when I use higher levels of PEEP, what is the likelihood that that is going to the recruited lung, or the likelihood that it's going to the baby lung, which would just result in overdistension. Those two things, when you do them regularly enough, you can do those things in literally under 2 minutes. And then I would determine whether or not I would start at a higher level of PEEP versus lower level of PEEP, or at airway closure versus not. And then you reassess the patient's tolerance of that PEEP level and their driving pressure, et cetera. But in terms of like where to start my PEEP, if they were recruitable and they were in severe ARDS, for example, I would start at a PEEP level of like 14, 15 if they were recruitable. If they weren't, then I would start somewhere around 10 and look at my driving pressure rather than start at 5, because I just have a problem putting somebody on 100% FiO2 on a PEEP of 5 for any reason. So I'll start at 10 and assess. But again, there's ways of assessing the possibility that your patient needs higher levels of PEEP without fancy tools, but it does take practice. I don't want to assume that everyone just run out and start doing RI ratios accurately. It does take practice and technique, but there are things you can do to give you more information about your patient's requirement for PEEP.
I think the simplest way to look at this is, if you don't have gadgets and you don't have a huge amount of special training or experience, look at the relationship between the PEEP increase and the plateau increase in volume control. I
Yep.
mean, if your driving pressure goes down or stays the same, you're probably in an okay spot. And then just look hemodynamically at what happened when you did that. Your SATs went up, you probably had a benefit from doing that. If you turn it up and your PEEP goes up by less than that, the chances are that you're recruiting now. Are you in that position that Tom described where, you're on that line between, optimal recruitment versus over distension and where those cross? That's a little harder to tell, but you can tell if you're turning your PEEP up and you're still getting benefit. So as long as that's happening, I say it's safe to turn it up and find that place where you're kind of in the flat part of the PV curve where your plateau is going up by the same amount as the PEEP, and then look at your SATs. As long as you're continuing to get benefit, your driving pressure stays relatively static, I think you can find a safe spot that way to set your PEEP. And that's probably the lowest common denominator at the bedside where you don't need special equipment and you need a minimal amount of special training on lung mechanics. My personal thoughts.
Yeah, so when the person was putting in the chat, I called it, that's what we call incremental. That's what we call incremental PEEP. And that's what we teach, because when I do our workshop here and we're teaching all of these different things with ventilator asynchrony, and we're teaching esophageal manometry, and we're going through all of this. The regional facilities in our institution are also able to take that class. They don't have all this stuff. And so the moment that she wrote that, I was like, oh, I know exactly what you're talking about. You're talking about what do I do when I don't have these tools? And then someone else wrote in the chat as well, like, is there any videos or photos of how to set it up with the arterial line waveform? Because I mean, even for me, like, I'm a Hamilton user. I don't have, obviously I have all the tools. But when you go to other places may not have that. And so it's like, is there Does anybody have anything that they've done or a video that they've set up or they've taken of that?
I don't have a video, but I wrote, I've written more than one policy using arterial disposable transducers that I can send if you email me via my email on the last slide. Actually, I'll just put it in the chat. Anybody
Yeah,
have
I do
parting
have videos.
shots?
I don't know if I had. I don't think I uploaded the video, but I did have a video on doing a measurement with your Artline transducer. The setting up is pretty straightforward because you just got to connect everything. But then it's like putting the proper air in the balloon catheter and then transducing. That's just like technique. But I did have a video for that. A different catheter than what I would have available now. You can always
Okay.
reach out and contact us.
Absolutely.
All right. Are we
So-
gonna need? I mean, we're over time now. We had 3 more, so maybe we got to do a part 2. I don't know. This always happens.
Well, I was going to say, like, I didn't want to get into talking about what I do with tracheostomy patients because that would lead into another whole 15 minutes.
Danielle talks too much. Doesn't
Too much. So that's why I was like, let me be quiet.
We knew this was
All
going to
right.
happen. There's
Yeah,
no
we
way we
do.
could talk about PEEP in 1 hour
Exactly.
with
That's kind of, yeah.
7 people.
That's ridiculous. Yeah. All right. Well, thank you, everybody. Thank you, Dr. Gioni. Thank you, everybody else. I put our website address in the chat, www.inspire-rt.com. I put my email address if you want our policy, my old policy for doing esophageal manometry. And I think we have a couple of other good links that people have put in there for Tom's online simulation tool, which is amazing. Nick, you put somebody's website in there too, I think.
It's just
So anyway-
it's just servos, yeah. They have like videos and stuff on there from education. It's like not bad.
Yeah. So we're over an hour now. We will make this video, this recording available to anyone who wants it. It'll be on LinkedIn. If you go to LinkedIn, if you're on LinkedIn and go to our Inspire Respiratory Critical Care page or my page, then you can find the links to all these things also.
We are, just to highlight this, we are a not-for-profit. This is like our volunteer work. Nobody's getting paid for this. We do not offer CEUs. This is straight up, like, if you're interested in learning, that's it. But we don't have CEUs. Sorry.
All right, guys.
All right.
Thank you so much.
Take care,
Appreciate
everyone.
your time. Yep.
Good to see you. See you.
All right.
Bye.
Bye-bye.
Thank you, everyone.